In the healthy term infant, ductal closure follows a predictable two-phase sequence. The initial functional closure occurs within 24 to 48 hours. This is driven by contraction of ductal smooth muscle in response to rising postnatal oxygen tension. The ductus has a unique oxygen sensing system. Increased arterial oxygen activates mitochondrial redox pathways, cytochrome P450 enzymes, and endothelin-1 signaling, all converging to increase intracellular calcium and trigger sustained constriction. As the placenta is removed from the circulation, prostaglandin E2 levels fall sharply. The placenta is the primary prostaglandin source, and the newborn lung rapidly clears circulating prostaglandin. In addition, ductal smooth muscle downregulates EP4 receptors after birth, further reducing vasodilatory input. The combined effect is loss of prostaglandin-mediated relaxation and dominance of oxygen-mediated contraction. If this functional closure persists, it sets the stage for anatomic remodeling, typically complete by 2 to 3 weeks in term infants. Remodeling includes endothelial proliferation, intimal cushion formation, and permanent fibrosis of the ductal wall, producing the ligamentum arteriosum. This second phase transforms a transient constriction into permanent anatomic closure. From a clinical standpoint, this timeline is central to neonatal management. Murmurs related to transitional ductal flow usually disappear within the first few days, while persistence beyond the second week raises suspicion for pathologic patency. Recognizing the distinction between early functional constriction and later anatomic remodeling guides both the timing of diagnosis and the approach to treatment when the ductus fails to close. The balance between closure and patency of the ductus arteriosus is determined by competing influences that shift dramatically at birth. Promoting closure, the most potent stimulus is the rise in oxygen tension after lung expansion. Ductal smooth muscle contains oxygen-sensitive channels and mitochondria-driven redox systems. Increased oxygen generates reactive intermediates that inhibit potassium channels, depolarize the smooth muscle, and allow calcium influx through L-type calcium channels, producing sustained constriction. The abrupt fall in circulating prostaglandin E2 following placental separation further removes a powerful vasodilator signal. In parallel, systemic vascular resistance rises as the placenta is eliminated, creating pressure gradients that favor left-to-right ductal flow and amplify shear forces on the ductal wall. Local mediators such as endothelin-1 and catecholamines also support vasoconstriction, while calcium channel activity reinforces smooth muscle contraction. In contrast, several factors oppose closure. Prostaglandins, especially PGE2, remain the strongest counterforce, maintaining ductal relaxation via cyclic AMP signaling. Nitric oxide and carbon monoxide, both endothelial-derived gaseous mediators, also contribute to ductal patency through cyclic GMP pathways. Systemic disturbances, particularly hypoxia and acidosis, blunt oxygen sensing and enhance vasodilatory tone, explaining why sick-term neonates or very preterm infants often struggle to achieve sustained closure. Clinically, this physiologic tug-of-war explains why indomethacin or ibuprofen, which inhibit prostaglandin synthesis, are effective in promoting closure, and why hypoxemia, acidosis, or sepsis often result in reopening of a previously constricted ductus. Recognition of these opposing forces is central to both the physiology of transition and to therapeutic strategies in the NICU. Spontaneous closure of the ductus arteriosus is strongly dependent on gestational maturity. In term infants, oxygen-mediated constriction and prostaglandin withdrawal are usually sufficient to trigger permanent closure, and failure to close is unusual. In contrast, the incidence of persistent ductus rises sharply as gestational age decreases. Extremely preterm infants are at highest risk, and the relationship is essentially inverse. The earlier the birth, the lower the likelihood of spontaneous closure. A critical factor is heightened sensitivity of the preterm ductus to prostaglandin E2. Circulating prostaglandin levels are higher in preterm infants, clearance by the immature lung is reduced, and the ductal wall maintains robust coupling of EP4 receptors to cyclic AMP amplifying vasodilatory signaling. Equally important is structural immaturity of the ductal smooth muscle. Preterm muscle fibers contain isoforms that are less capable of sustained contraction, and expression of rho kinase, a key mediator of calcium sensitization, is diminished. Together, these factors blunt the normal oxygen-induced contractile response and leave the vessel biased toward patency. Clinically, the difference is striking. Infants born at less than 26 weeks gestation have only about a 50% chance of spontaneous closure by 2 months of age. This persistent patency contributes to complications such as pulmonary overcirculation, heart failure, and increased risk of intraventricular hemorrhage and necrotizing enterocolitis. For the bedside clinician, gestational age serves as a key predictor of whether conservative management is reasonable or if pharmacologic or surgical closure will be necessary. The natural course of ductal closure varies dramatically with gestational age. In term infants, spontaneous closure is the rule, with nearly all closing by 3 weeks of life. In preterm infants, the incidence of persistence rises sharply as gestational age falls. Infants over 28 weeks gestation close spontaneously in more than 90% of cases, while those born before 26 weeks often remain persistently patent without treatment. Several factors further delay closure, including immaturity of ductal smooth muscle, systemic infection, hypoxemia, and the absence of antenatal steroid exposure. Recognizing these patterns helps identify which infants are likely to close on their own and which require intervention. A patent ductus arteriosus is defined as persistence of the fetal connection between the pulmonary artery and the descending aorta after birth. In healthy term infants, this vessel constricts functionally within 1 to 2 days and undergoes anatomic remodeling to a ligament by the 2nd to 3rd week. When the ductus remains open beyond this expected period, it becomes pathologic. The physiologic transition after birth drives shunting across the open vessel. As pulmonary vascular resistance falls below systemic levels, blood flows left to right from the aorta into the pulmonary artery. This redirection of systemic output results in pulmonary overcirculation and systemic steal. The clinical impact is not confined to the heart. It extends to the lungs, gastrointestinal tract, kidneys, and brain. Defining PDA in this way sets the stage for evaluating why closure matters and why untreated patency can drive significant morbidity. The ductus arteriosus does not present uniformly. Anatomic variation directly influences hemodynamics, procedural approaches, and long-term outcomes. The classic Type A, or conical configuration, features a wide aortic ampulla tapering toward the pulmonary end. This shape is most favorable for transcatheter device closure. Type B, or window ductus, is short with a broad pulmonary opening and constriction at the aortic end. This morphology can complicate device anchoring. Type C, or tubular ductus, maintains a uniform caliber without narrowing at either end, often associated with persistent shunting due to the absence of natural constriction points. Type D, or saccular ductus, has constrictions at both ends with a dilated mid-segment, creating flow turbulence and an increased risk for thrombus or endarteritis. Type E, or elongated ductus, follows a long, narrow course with constriction at the pulmonary end. Closure strategies may require tailored device selection. Finally, the Type F, or fetal configuration, is most often observed in preterm infants. It is long, wide, and tortuous, reflecting developmental immaturity and posing particular challenges for both spontaneous closure and intervention. Once the ductus arteriosus remains open after birth, the hemodynamic burden is dominated by the steal phenomenon. As pulmonary vascular resistance falls and systemic resistance rises, blood preferentially diverts from the aorta into the low-resistance pulmonary circuit. This left-to-right ductal shunting delivers excess flow to the lungs while robbing systemic organs of perfusion. The pulmonary circulation becomes overloaded. Increased venous return from the lungs creates left atrial and left ventricular dilation, raising filling pressures and eventually impairing systolic performance. At the same time, alveolar capillaries are exposed to excess volume and pressure, which reduces compliance and worsens gas exchange. Clinically, this manifests as difficulty weaning from respiratory support, oxygen dependence, and pulmonary edema. Systemic hypoperfusion is the parallel consequence. Aortic runoff into the ductus compromises diastolic flow to critical organs. Doppler studies demonstrate absent or reversed diastolic flow in the mesenteric renal and cerebral arteries. The result is renal oliguria, gastrointestinal ischemia predisposing to necrotizing enterocolitis, and impaired cerebral perfusion that may contribute to intraventricular hemorrhage or white matter injury. When the left ventricle can no longer compensate for the chronic volume load, overt congestive heart failure develops. Signs include tachycardia, hepatomegaly, and poor feeding, often in the context of respiratory deterioration. Recognition of this physiologic cascade, the pulmonary overcirculation, systemic steal, and ultimate failure of cardiac compensation, is essential for determining which infants require intervention to close the ductus. A hemodynamically significant PDA produces a characteristic constellation of cardiovascular and systemic findings. The cardiovascular picture reflects the left to right shunt. Infants often present with hypotension and oliguria, consequences of systemic diastolic runoff. On exam, a hyperdynamic precordium is common as the left ventricle struggles with the excess volume load. Bounding pulses and a widened pulse pressure are particularly distinctive, representing rapid diastolic runoff into the pulmonary circulation. Systemic effects extend beyond blood pressure. To maintain perfusion, neonates mount peripheral vasoconstriction, which may be visible as cool extremities and delayed capillary refill. Despite these compensations, systemic oxygen delivery falls, often accompanied by metabolic acidosis. Respiratory compromise is equally prominent. Pulmonary overcirculation increases as hydrostatic pressure in the pulmonary capillaries, promoting interstitial and alveolar edema. This results in tachypnea, retractions, and worsening oxygenation. Many infants develop prolonged ventilator dependence or fail repeated extubation attempts. Pulmonary hemorrhage may complicate severe cases. The nutritional impact becomes evident over time. Intestinal ischemia contributes to feeding intolerance, and the chronic increase in metabolic demand, coupled with inefficient systemic perfusion, leads to poor growth and failure to thrive. These systemic manifestations distinguish a trivial ductus from one requiring intervention, emphasizing the need for careful correlation of clinical findings with echocardiographic evidence of shunt significance. The clinical profile of a patent ductus arteriosus differs substantially between term and preterm infants. In term neonates, the ductus is usually an isolated lesion. A small PDA may remain clinically silent, discovered only incidentally. When more significant, the classic continuous machinery murmur emerges after pulmonary vascular resistance falls, typically within the first days of life. These infants generally maintain good cardiopulmonary reserve early on, but the likelihood of spontaneous closure drops sharply once the neonatal period has passed. Beyond that point, ductal patency often requires catheter-based or surgical intervention. In preterm infants, the ductus rarely exists in isolation. It compounds the effects of global immaturity, interacting with fragile lungs, vulnerable gut, and delicate cerebral vasculature. The hemodynamic shunt can worsen bronchopulmonary dysplasia by promoting pulmonary edema, contribute to necrotizing enterocolitis through mesenteric hypoperfusion, and increase the risk of intraventricular hemorrhage by altering cerebral blood flow. Respiratory complications are usually the dominant presentation. These babies often fail extubation attempts, require escalating ventilatory support, and develop chronic oxygen dependence. Recognizing these differences is essential. In term as infants, PDA often presents as a structural cardiac problem with characteristic auscultatory findings, while in the preterm population it is primarily a multisystem disorder, driving morbidity across the pulmonary, gastrointestinal, and neurologic systems. A persistent ductus in the preterm infant is rarely an isolated finding. It amplifies vulnerability across multiple organ systems. In the lungs, a large left-to-right shunt increases pulmonary venous return and interstitial edema, which impairs alveolar development and contributes to bronchopulmonary dysplasia. The gastrointestinal tract is equally sensitive. Mesenteric blood flow is compromised by diastolic runoff into the ductus, predisposing infants to necrotizing enterocolitis and increasing feeding intolerance. Cerebral circulation is also affected. Fluctuating flow and pressure changes across fragile germinal matrix vessels increase the risk of intraventricular hemorrhage. The impact extends to growth as well. Chronic respiratory effort combined with recurrent hypoperfusion elevates metabolic demands and leads to poor weight gain, even when aggressive nutritional support is provided. Renal dysfunction is another recognized complication. Reduced renal perfusion lowers glomerular filtration and can present as oliguria with rising creatinine, which complicates fluid management. This combination of morbidities shows that PDA in the preterm infant is more than a cardiac lesion. It is a systemic condition with far-reaching consequences, and timely recognition of these associations is essential to guide decisions about intervention. Certain bedside findings sharpen recognition of a significant ductus. A common pitfall is assuming a large PDA always produces a loud murmur. In fact, very large ducts may be silent due to low flow velocity. Bounding peripheral pulses with a widened pulse pressure are more reliable signs of significant runoff. Treatment failures are most common in extremely low birth weight infants, particularly when compounded by sepsis or hypoxemia, both of which elevate prostaglandin activity. Daily monitoring of urine output, serum creatinine, systemic perfusion, and feeding tolerance is essential during therapy. Most importantly, in the preterm population, a PDA should never be considered a purely cardiac lesion. Its effects extend systemically, influencing pulmonary, gastrointestinal, renal, and neurologic outcomes. Conservative management is designed to reduce the hemodynamic stress of a persistent ductus while awaiting natural closure or preparing for therapy. Restricting fluids to about 120 to 150 milliliters per kilogram per day limits pulmonary venous return and helps prevent pulmonary edema. Diuretics such as furosemide or thiazides further manage volume overload. But furosemide also stimulates prostaglandin release, which can keep the ductus open. This paradox explains why its use requires caution. Increased pulmonary blood flow reduces lung compliance, so ventilatory adjustments such as higher mean airway pressures may be necessary. Nutritional optimization with calorie-dense feeds, typically 24 to 30 kilocalories per ounce, helps compensate for increased metabolic demand and limited fluid volumes. Correction of comorbid conditions, anemia, hypoxemia, or infection lowers prostaglandin activity and can reduce shunt magnitude. These measures do not induce closure, but stabilize systemic and pulmonary physiology, buying time for spontaneous closure or for safe initiation of pharmacologic therapy. Echocardiography remains the gold standard for assessing a patent ductus arteriosus, a ductal diameter greater than 1.5 millimeters, and a left atrial to aortic root ratio exceeding 1.4 are reliable markers of hemodynamic significance. Doppler findings of absent or reversed diastolic flow in the descending aorta, mesenteric or cerebral arteries reflect systemic stele, while left ventricular dilation or impaired systolic performance confirm volume overload. Biomarkers such as BNP or NT pro-BNP rise in proportion to shunt magnitude and can serve as adjunctive tools, although they lack specificity on their own. Near-infrared spectroscopy provides continuous information on cerebral and mesenteric oxygenation and may help gauge the impact of ductal shunting on regional perfusion. Together, these measures allow clinicians to differentiate an incidental PDA from one requiring intervention. The decision to intervene depends on gestational maturity and the physiologic impact of the shunt. Infants over 28 weeks gestation or weighing more than 1,000 grams frequently close their ductus spontaneously, making observation appropriate if no symptoms are present. In contrast, when shunting causes pulmonary edema, systemic hypoperfusion, growth failure, or feeding intolerance, closure is indicated. Timing is critical. In the first 72 hours, ductal tissue is highly responsive to prostaglandin withdrawal, making pharmacologic therapy most effective. Indomethacin is favored in extremely preterm infants under 26 weeks because it not only promotes closure, but also reduces the incidence of intraventricular hemorrhage by stabilizing cerebral blood flow. This dual role explains why it remains the drug of choice in this population despite renal and gastrointestinal side effects. Recognizing who can be safely observed and who requires early treatment prevents both overtreatment of trivial PDAs and delayed intervention in infants with significant systemic compromise. PDA management follows an escalation pathway that matches therapy intensity to clinical severity. First-line stabilization uses fluid restriction, diuretics, respiratory support adjustments, and higher-calorie nutrition to limit the effects of pulmonary overcirculation. If the ductus remains hemodynamically significant, medical therapy is initiated. Indomethacin is most effective in extremely preterm infants and provides neuroprotection against intraventricular hemorrhage. Ibuprofen achieves comparable closure with less impact on renal and mesenteric perfusion, but does not protect the brain. Acetaminophen is increasingly used when nonsteroidal agents are contraindicated, though efficacy is reduced in infants younger than 28 weeks. If pharmacologic therapy fails or cannot be used, definitive closure becomes necessary. Surgical ligation provides a reliable cure, but carries risks such as vocal cord paralysis and post-ligation cardiac syndrome. Transcatheter closure, particularly with devices designed for very small infants, is an emerging alternative with fewer respiratory complications, but requires specialized expertise. The algorithm highlights progressive escalation, ensuring infants are neither exposed to unnecessary risk nor left with ongoing systemic compromise. Conservative management of a patent ductus arteriosus focuses on minimizing the hemodynamic consequences while allowing time for spontaneous closure. The first step is fluid restriction, typically limiting intake to 120 to 150 milliliters per kilogram per day. By reducing intravascular volume, we decrease left-to-right shunting across the ductus and help limit pulmonary overcirculation. Diuretics may be used if signs of volume overload are present, but they must be approached cautiously. While they can relieve pulmonary edema, overuse can lower intravascular volume excessively, further activating ductal flow and worsening systemic hypoperfusion. Respiratory support adjustments are often required. Infants with significant shunts may need higher levels of positive end expiratory pressure or adjustments in ventilator strategy to counteract pulmonary edema and maintain adequate gas exchange. Nutritional optimization is critical, as a hemodynamically significant ductus increases metabolic demand. Fortification of feeds to 24 to 30 kilocalories per ounce provides sufficient calories without increasing fluid burden, supporting growth even in the setting of fluid restriction. Finally, conservative care must include aggressive treatment of comorbidities. Infection, anemia, and hypoxemia all exacerbate ductal patency by promoting prostaglandin release or reducing oxygen-mediated constriction. Addressing these conditions improves the likelihood of spontaneous closure and reduces morbidity. Together, these measures aim to stabilize the infant, mitigate the complications of ductal shunting, and provide a bridge to closure, either spontaneous or with pharmacologic or surgical intervention if needed. Indomethacin remains a cornerstone therapy for ductal closure in preterm infants. Its mechanism is non-selective cyclooxygenase inhibition, which blocks prostaglandin synthesis. By lowering prostaglandin E2 concentrations, indomethacin removes the dominant vasodilatory influence on ductal smooth muscle, allowing oxygen-mediated constriction to proceed. The drug is most effective in the early transitional period, particularly within the first 72 hours of life, when ductal tissue still responds robustly to prostaglandin withdrawal. Success rates vary from 60 to 90% and are strongly linked to gestational maturity. More mature preterm infants achieve closure more reliably, whereas extremely preterm infants have higher failure and reopening rates. Standard therapy involves 3 intravenous doses administered over 3 to 7 days. Dosing regimens are age-based, accounting for maturational changes in renal clearance. The half-life of indomethacin is about 21 hours in term infants, but is substantially prolonged in very preterm infants, necessitating extended dosing intervals and careful monitoring. From a clinical perspective, indomethacin provides both diagnostic and therapeutic value. A closing murmur and improving hemodynamics confirm ductal responsiveness. while persistence of patency may signal the need for repeat treatment or alternative strategies, such as ibuprofen, acetaminophen, or surgical ligation. Indomethacin dosing for ductal closure is adjusted to postnatal age because clearance improves steadily after birth. In the first 48 hours of life, the recommended dose is 0.1 to 0.2 milligrams per kilogram per dose. Between days 3 and 7, dosing increases to 0.2 to 0.25 milligrams per kilogram. Beyond the first week, 0.25 to 0.3 milligrams per kilogram per dose is used to account for maturational changes in metabolism and renal excretion. Each dose is given intravenously over 30 minutes, typically at 24-hour intervals for a 3-dose course. This schedule provides sustained prostaglandin suppression while allowing time to monitor for drug toxicity between doses. Close surveillance during therapy is essential. Indomethacin reduces renal perfusion, so urine output and serum creatinine must be tracked to identify acute kidney injury. Its antiplatelet effect requires attention to bleeding parameters, especially in extremely preterm infants at risk for intraventricular hemorrhage or gastrointestinal bleeding. Strict fluid balance monitoring is also important, since oliguria or rising blood urea nitrogen are common early signs of intolerance. This age-stratified regimen maximizes efficacy while minimizing risk, and reinforces the principle that indomethacin dosing is never one-size-fits-all, but must be tailored to the infant's age and physiologic maturity. Indomethacin must be used selectively, as its cyclooxygenase inhibition can compromise blood flow to multiple organ systems. Absolute contraindications include significant renal dysfunction or oliguria, since the drug further reduces renal perfusion. It should also be avoided in the setting of active bleeding or coagulopathy, given its antiplatelet effects. Necrotizing enterocolitis is a strict exclusion because mesenteric vasoconstriction worsens intestinal ischemia. Severe heart failure is another contraindication, since further reduction in systemic perfusion may precipitate collapse. The major side effects are linked to its impact on regional circulation. Indomethacin decreases renal, mesenteric, and cerebral blood flow. Renal effects are the most clinically significant. Oliguria and rising creatinine are common, but usually reversible with drug discontinuation. Gastrointestinal complications stem from reduced gut perfusion and can increase the risk of perforation or progression of intestinal disease. Cerebral blood flow reduction raises theoretical concern for intraventricular hemorrhage, though risk is greatest in extremely preterm infants already predisposed to fragile cerebral vasculature. These risks highlight the need for vigilant monitoring of urine output, serum creatinine, perfusion status, and abdominal examination throughout therapy. The decision to treat must always balance the potential for ductal closure against the possibility of precipitating organ injury. Indomethacin has a unique role beyond ductal closure. It decreases the incidence of intraventricular hemorrhage in extremely preterm infants. This neuroprotective effect is linked to its influence on cerebral blood flow and autoregulation. By stabilizing cerebral perfusion, indomethacin reduces fluctuations that contribute to germinal matrix vessel rupture. Importantly, this benefit is specific to indomethacin. Neither ibuprofen nor acetaminophen confer the same protection against intraventricular hemorrhage, even though they achieve comparable rates of ductal closure. For this reason, indomethacin is sometimes chosen not only for PDA treatment, but also for prophylaxis in infants at highest risk for severe IVH. The decision to use indomethacin prophylactically requires careful balance. While the potential to prevent a devastating neurologic complication is significant, the risks of renal impairment, gastrointestinal complications, and bleeding remain. Each course must be individualized, weighing the likelihood of benefit against the known adverse effect profile. At the bedside, this distinction often guides therapy in the smallest, most vulnerable infants, where neuroprotection is as critical as ductal management. Ibuprofen provides an effective alternative to indomethacin for pharmacologic ductal closure. Its mechanism is the same, non-selective inhibition of cyclooxygenase, lowering prostaglandin E2 levels and permitting ductal constriction. Clinical trials demonstrate comparable efficacy to indomethacin in achieving closure. The advantages of ibuprofen are clinically meaningful. Compared to indomethacin, ibuprofen is associated with lower rates of necrotizing enterocolitis and less renal impairment. It also produces less reduction in cerebral blood flow, making it particularly useful in extremely preterm infants who are already vulnerable to intraventricular hemorrhage. These safety differences have made ibuprofen the preferred first-line agent in many centers. Another practical advantage is availability in both intravenous and oral formulations, allowing flexibility in administration when IV access is limited or enteral therapy is feasible. The standard regimen is a loading dose of 10 milligrams per kilogram, followed by 2 additional doses of 5 milligrams per kilogram at 24 and 48 hours. This 3-dose course mirrors indomethacin in structure but offers a more favorable side effect profile. In practice, ibuprofen's similar efficacy with improved safety has shifted the pharmacologic approach to PDA management. Though treatment decisions must still weigh gestational age, comorbidities, and the hemodynamic significance of the ductus. Ibuprofen can be administered intravenously or through the orogastric route, and clinical studies show that enteral dosing is just as effective as IV therapy for ductal closure. This flexibility is valuable in settings where intravenous access is difficult or the infant is otherwise stable enough to tolerate oral administration. Contraindications overlap with those for indomethacin, including significant renal dysfunction, active bleeding, or necrotizing enterocolitis. However, ibuprofen tends to spare renal, mesenteric, and cerebral blood flow compared with indomethacin, making it a safer choice in many extremely preterm infants. One caveat is its interaction with bilirubin metabolism. Higher ibuprofen doses may displace bilirubin from albumin binding sites, increasing the fraction of free bilirubin and raising theoretical concern for kernicterus in very low birth weight infants with hyperbilirubinemia. This risk is dose-related and must be weighed carefully in jaundiced preterm infants. A critical difference between the two agents is neuroprotection. Indomethacin has been shown to reduce the incidence of intraventricular hemorrhage when given prophylactically, an effect not replicated with ibuprofen. Thus, while ibuprofen offers comparable efficacy and a better safety profile for PDA closure, it does not confer the same preventive benefit against IVH. Acetaminophen has emerged as a third option for pharmacologic ductal closure, particularly valuable when NSAIDs are contraindicated. Its mechanism differs subtly from indomethacin and ibuprofen. Instead of blocking cyclooxygenase directly, acetaminophen inhibits the peroxidase moiety of prostaglandin H2 synthetase, ultimately reducing prostaglandin production and removing the vasodilatory stimulus that maintains ductal patency. Randomized trials suggest efficacy comparable to indomethacin and ibuprofen, with closure rates in a similar range. Both oral and intravenous routes have been studied, offering flexibility in administration. The standard regimen is 15 milligrams per kilogram every 6 hours for 3 days, given either orally or intravenously. The key advantage is its safety profile. Acetaminophen does not significantly reduce renal, mesenteric, or cerebral blood flow, and thus carries fewer contraindications than NSAIDs. It can be used in infants with renal dysfunction, thrombocytopenia, or active bleeding, where indomethacin or ibuprofen would be unsafe. While longer-term safety and neurodevelopmental outcomes are still under investigation, acetaminophen has become a practical alternative in many NICUs, especially for extremely preterm infants with fragile physiology or high risk for NSAID-related complications. Acetaminophen offers several advantages compared with NSAIDs in the treatment of PDA. It does not significantly impair renal perfusion, and its effect on mesenteric and cerebral blood flow is minimal. This makes it a useful option when NSAIDs are contraindicated due to renal dysfunction, thrombocytopenia, or gastrointestinal compromise. However, some emerging concerns require caution. Epidemiologic studies have raised questions about possible neurocognitive impairment with prenatal acetaminophen exposure, though causality has not been established. In the neonatal setting, hypotension has been reported after intravenous administration, emphasizing the need for close hemodynamic monitoring. Efficacy may also be gestational age dependent. Data suggests that acetaminophen may be less effective in infants born before 28 weeks, where ductal tissue is particularly immature and highly prostaglandin sensitive. In these extremely preterm infants, treatment failure and the need for alternative closure strategies are more common. Taken together, acetaminophen expands the pharmacologic armamentarium for ductal closure, especially in fragile infants who cannot tolerate NSAIDs, but its role continues to be refined as longer-term outcome data accumulate. Comparative studies highlight important differences in pharmacologic closure of the ductus. Indomethacin remains the most effective agent in extremely preterm infants. In those born before 28 weeks, its relative risk of closure exceeds 3 compared with no therapy, making it the gold standard in this population. Ibuprofen provides moderate effectiveness with a relative risk of about 2 for closure, while it spares renal, mesenteric, and cerebral perfusion compared with indomethacin. Its success rate is somewhat lower in the smallest infants. Acetaminophen shows promise as a safer option when NSAIDs are contraindicated, but in very preterm infants, its effect is limited. Relative risk for closure is closer to 1.3, reflecting higher rates of treatment failure in this group. A consistent theme across all agents is the timing of therapy. Earlier treatment, particularly within the first 72 hours of life, achieves higher success rates. This reflects the ductus being more responsive to prostaglandin withdrawal before structural changes set in. For the bedside clinician, the choice of therapy must balance efficacy with safety. Indomethacin remains the preferred drug for the most immature infants. Ibuprofen is widely used for its better safety profile, and acetaminophen is reserved for cases where nonsteroidal anti-inflammatory drugs cannot be given. Surgical ligation remains an important option for infants with Ductus Arteriosus when medical therapy is unsuccessful or contraindicated. Indications include failure of closure after indomethacin, ibuprofen, or acetaminophen. Contraindications to pharmacologic therapy, such as renal failure, NEC, or active bleeding. Hemodynamically significant, PD, causing persistent cardiopulmonary compromise, and growth failure that persists despite maximal medical management. The standard surgical approach is through a left thoracotomy, typically via the fourth intercostal space, providing direct access to the ductus. The technique involves either simple ligation or division of the ductus arteriosus. Both methods achieve permanent anatomic closure and eliminate the left to right shunt. While ligation is highly effective, it is not without risk. Postoperative complications can include recurrent laryngeal nerve injury, chylothorax, or left lung hypoplasia if pleural adhesions develop. Some infants also experience transient hemodynamic instability due to abrupt changes in preload and afterload. Despite these risks, surgical ligation provides definitive therapy when other measures fail, and for many extremely preterm infants with refractory PDA, it remains the only effective path to stabilization and growth. Surgical ligation of the ductus is highly effective, but complication rates are substantial, particularly in extremely low birth weight infants. Between 20 and 60% develop postoperative problems. One of the most frequent is unilateral vocal cord paralysis from recurrent laryngeal nerve injury, which can cause persistent stridor, feeding difficulty, and prolonged respiratory support. Pulmonary complications such as pneumothorax and chylothorax are also encountered. A unique and clinically significant complication is post-ligation cardiac syndrome. This occurs in 30 to 50% of infants under 1,000 grams and is characterized by profound hypotension requiring inotropic support. The mechanism involves abrupt hemodynamic shifts after ductal closure, compounded by impaired adrenal function and decreased systemic vascular tone in the preterm infant. Recognition is essential since these infants often need volume resuscitation, hydrocortisone, and careful ventilatory management in the immediate post-operative period. Long-term consequences are equally important. Infants requiring surgical ligation have higher rates of bronchopulmonary dysplasia and neurodevelopmental impairment compared with those whose ductus closed medically or spontaneously. Whether this reflects the surgery itself or the severity of underlying illness remains debated, but it underscores the importance of reserving ligation for cases where other strategies have failed. Transcatheter closure has become an increasingly important alternative to surgical ligation for selected infants with patent ductus arteriosus. Device options include traditional coil occlusion and, more recently, the Amplatzer Piccolo occluder, specifically designed for use in premature infants. Indications are small to moderate PDAS with suitable ductal anatomy. Advances in device technology now permit closure in infants weighing less than 1,000 grams, particularly with the Piccolo device, expanding eligibility to the extremely preterm population once limited to surgery. The advantages of catheter-based closure are compelling. It avoids thoracotomy and its attendant risks, reduces the likelihood of post-ligation cardiac syndrome, and often allows faster recovery with less disruption to respiratory status. Limitations remain. Success depends on favorable ductal anatomy and the availability of specialized expertise, usually at high-volume centers. Even in experienced hands, complications occur in about 5 to 10% of cases, including device embolization, obstruction of adjacent vessels, or vascular injury. Mortality risk is low, but not negligible, around 2% in published series. Despite these risks, transcatheter closure represents a major advance in PDA management, offering a definitive therapy that may reduce morbidity compared with surgical ligation when performed in appropriate candidates. Management of PDA remains one of the most debated topics in neonatology. Some centers favor early targeted closure, aiming to prevent complications such as bronchopulmonary dysplasia, necrotizing enterocolitis, and intraventricular hemorrhage. Others take a conservative approach, citing evidence that many infants, especially those over 28 weeks, will close their ductus spontaneously, and that routine pharmacologic or surgical closure has not consistently improved long-term neurodevelopmental outcomes. Early closure carries the potential benefit of reducing cardiopulmonary stress, while conservative strategies minimize exposure to drug toxicity and operative risk. The current consensus is shifting toward individualized management, with decisions guided by gestational age, clinical stability, and echocardiographic evidence of hemodynamic significance. For exam purposes, it is critical to recognize that both strategies are valid and that practice patterns vary by institution. Persistent PDA in preterm infants amplifies risks across multiple organ systems. Left-to-right shunting increases pulmonary venous return and interstitial edema, predisposing to bronchopulmonary dysplasia. Mesenteric hypoperfusion contributes to necrotizing enterocolitis, while fluctuating cerebral blood flow raises the risk of intraventricular hemorrhage and white matter injury. Chronic systemic hypoperfusion and increased metabolic demand impair growth despite adequate nutrition. Early closure improves respiratory stability, supports growth, and reduces neurologic risk by limiting exposure to recurrent hypoperfusion. Delayed closure is associated with higher rates of developmental delay and prolonged ventilator dependence. Beyond infancy, persistent patency increases the risk of infective endocarditis and pulmonary hypertension, though late persistence is rare. Once closure is achieved, most infants show improved growth, better pulmonary outcomes, and freedom from cardiovascular complications. Structured follow-up should assess neurodevelopment, pulmonary function, and growth trajectory to ensure that infants not only survive, but achieve the best possible outcomes. Families need clear explanation of the natural history and treatment options for PDA. Most larger preterm and term infants will achieve closure without intervention, and this reassurance prevents unnecessary anxiety. When therapy is needed, it is because the ductus is hemodynamically significant and causing systemic effects, not just because it is open. Parents should understand that PDA in the very preterm infant is not only a cardiac problem, it impacts the lungs, gastrointestinal tract, kidneys, and brain. This multi-system involvement is why closure is sometimes prioritized even when the murmur is subtle. Risks and benefits of each strategy, observation, pharmacology, surgery, or catheter closure, should be outlined in plain terms. Practice varies among centers, with some favoring early closure and others using a conservative approach, so preparing families for these differences helps align expectations. Above all, it is important to emphasize that with appropriate management, most infants achieve good long-term outcomes, including normal growth and development,